Well, welcome everybody to ICMDA webinars. I'm Dr. Peter Saunders, the CEO of the International Christian Medical and Dental Association. And today's webinar, we have speaking to us Dr. Katherine Welch on the role of health professionals in addressing human trafficking. So it's my pleasure now to introduce Dr. Katherine Welch, who I had the great privilege of meeting just a year or so ago and was incredibly impressed to learn about the wonderful work that she's doing in addressing human trafficking. So her topic is the role of health professionals in addressing human trafficking. And Katherine is an MD. She's an American physician. She's a member of the CMDA US, that's the Christian Medical and Dental Association of the US. And she is also the director of Relentless, which she'll tell us a bit more about when she speaks. Katherine's been serving oppressed, trafficked, and exploited people since the year 2000, and her journey started at a mission hospital on the Thailand-Myanmar border, where she first encountered human trafficking through her patients and other colleagues in Thailand. And I know we've got lots of listeners today from Southeast Asia, so that will be particularly of interest to you. And since then, she's worked with the marginalized and oppressed to fight slavery and other injustices in over 20 countries worldwide. So you're very welcome here, Katherine, and we really look forward to hearing you speak on the role of health professionals in addressing human trafficking. Thank you.
Well, greetings from Berlin, which is where I'm located right now. I wish I could see you. It's wonderful we can all get together for these webinars. It's unfortunate that we can't meet in person and I can see all of your wonderful faces. So yeah, before I get started on the talk, then I'll have a brief introduction to Relentless. I started Relentless in 2011, and I had the idea after working in Thailand and China for about 11 years, I had the idea of what would it look like if a doctor spent her entire time and all of my energy addressing the intersection between health and human trafficking. And so then I moved from China back to Thailand and I launched Relentless. And just briefly, an overview, Relentless has three main aspects, and that would be one, I do clinical care of trafficking survivors of labor exploitation, a whole spectrum of slavery. I do a lot of equipping of healthcare professionals, such as yourselves, so that they can learn more about how to integrate their unique skills and interests in fighting human trafficking around the world. Most of the time, most of my energy is spent really building the capacity of anti-trafficking organizations that don't necessarily have contact with other doctors or nurses to help them understand how they can build a more robust healthcare component to their interventions. And so that's a huge spectrum. And I've worked in over 30 countries. So perhaps when we can travel more widely again, let me know if I can come to visit you and do some training there. So, but let's talk about what are the basic roles of the healthcare professionals. So disclosure statement, we're going to talk about what the roles are. We're gonna have a brief description of human trafficking, and then I'll describe how a little bit about trauma-informed care. But basically, when we talk about human trafficking, there is a protocol that was developed by the United Nations 20 years ago, but I'm going to distill it into three main components. And one is that there's movement or confinement of an individual. There's removing of the personal agency. That is to say that they do not have control over their lives, they can't travel, they do not have control over the money that they're earning, they may not have control over where they stay or being able to go out and get food or access healthcare services. They're basically limited in what they can decide to do or not do. and they're working for the financial profit or gain of somebody else. So those are three main distilled components of what makes it human trafficking. And so human trafficking and slavery are not the same thing. There's a whole spectrum of slavery I can get into later. But you hear modern day slavery and human trafficking, not exactly the same thing, because human trafficking tends to be defined by governments as what is human trafficking. It's a geopolitical definition more than sort of a broadly ill-defined exploitation or slave-like conditions. Not to spend a lot of time on that, but if you're confused sometimes about the definition, you are not alone. So, but as healthcare professionals, we like to have evidence and data, but the problem is that it's extremely difficult to come up with a universal yardstick by which exploitation can be measured. And so we have alphabet soup of all these UN agencies, IOM, ILO, TIP report, lots of different organizations that are counting slaves, counting human trafficking victims, but they're using different methodology and different indicators, and different countries have different laws and different definitions of what human trafficking is within their borders. So tracking measures are difficult. So when you see the difference between, oh, there's 40 million people in slavery or 25 million or different things, it just depends on what who's counting what numbers. And so it's hard to get a real definite baseline. Basically, there's millions of people and it's way too many. That's what you need to know. There's too many people being victims of human trafficking. So one of the points I'd like to make is that human trafficking does not start when someone finds themselves in an exploitative situation, and it does not end when they're suddenly liberated or rescued, because the damages of the trauma that happens during trafficking or even before and then after, it's not the only, it's the trafficking experience lives with this person well after they're out. And then also there's a lot of vulnerabilities that set someone's up to being more likely to be trafficked than somebody else. So forms of trafficking briefly, I'm sure in your various countries, you're familiar with these: forced labor, debt bondage, sex trafficking, child labor, child soldiers, child sex trafficking, pornography, child pornography, and selling for adoption. Forced marriage is also considered a form of human trafficking. And of course, as physicians, we should be concerned about organ trafficking. And then there's involuntary domestic service, the person who's helping out in the home of somebody, such as rich people or diplomats. But the one thing we are talking about today is that trafficking is a health issue. And so this is Chris Byer back in the Lancet. This was published back in 2000 or 2004, I forget. He's published several statements in the Lancet. And back 10, 15, 20 years ago, the fact that human trafficking is a healthcare issue was recognized, but we have been slow to get involved, and other organizations have been slow to recognize that physicians play a valuable role in fighting human trafficking. But what are our roles? So let's talk about Nina. So Nina was sex trafficked. Nina's 19 years old. She has 4 years experience of being trafficked for sex services. And she comes to you because she is now out of the sex trafficking situation, and an organization has brought her to your clinic, and she has chronic headaches, neck pain. She also has some gastrointestinal distress, and she's on and off anxious and depressed. But when you examine her, she has no real findings. You might do a blood test. She's a little bit anemic. She's might be a little bit underweight. But their physical exam does not explain the profound symptoms, the headaches and the chronic pain, the gastrointestinal problems. So we're going to get into more about what that, but I want to talk to you about also what else we can do for Nina as doctors besides human trafficking, and then also why we should care, because doctors, nurses are on the front lines of human trafficking, which means we might see Nina as someone who's being brought by an aftercare assistance program like Nina was, but there are studies that show between 20%, maybe up to 80% of people who are in a trafficking situation actually see a doctor while they're being trafficked. So we are largely unprepared and ill-equipped to identify and handle a case of human trafficking because we're not recognizing, we don't know what to do. And if we do identify someone as being trafficked, what do we do after? But there's also different ways, different things that we can do. Of course, I've just outlined that we have service. We have direct care of survivors and victims. But there's also prevention and addressing risk factors. There's identification. Like if Nina was someone who was not yet, who is still in a trafficking situation, then we can identify her and refer her for services. We need research, advocacy, training, and this whole way of addressing human trafficking is multidisciplinary. We need to partner with other people. So I'm going to go over these in more detail. So I'm a pediatrician, so I'm all about prevention and stopping problems before they happen. So the best intervention is prevention. So prevention looks like addressing child abuse and neglect. Maybe you've heard of the adverse childhood experiences studies, that the more adverse experiences a child experiences, then the more likely they are to have chronic healthcare problems and then have problems like substance abuse. And they're also more vulnerable to being trafficked. There's young adults and youth that are at risk for human trafficking. Migrants and refugees are another huge population that are at risk. So, and then we all have interaction, we all have opportunities to do prevention. And also, I would add that there's different models of prevention of human trafficking. But the one that's being put forward more and more is the public health approach to human trafficking, and not the prosecution approach to stopping human trafficking, for example. But that's also, I'm going to put that aside. I'm doing a big overview on the roles of healthcare doctors. So advocacy. Advocacy means to change what is into what should be. We are advocating for our patients by raising awareness about human trafficking in general, and raising awareness with your peers and colleagues in the hospital or clinic, but also in the general population. We need to advocate for patient rights. The victims of human trafficking have no money. They're usually in another country from their home country, but not always. So advocating rights for access to healthcare, for example, and survivor services, such as multidisciplinary care, or a lot of times the survivors have problems with continuity of care. They have problems with long-term access to care, and they have problems with long-term access to mental health services. And so as physicians, we can use our voices to say, you know, these people need a lot more than what we're giving them. So research, as I said before, is more than just generating numbers for epidemiological purposes, but we need research in a local context. What does trafficking look like in Sierra Leone? Or what does it look like in Indonesia? Or what does it look like in Greece? And so there's a local context. There's a lot of research being done in America, Western Europe. I've seen a few studies coming out of some African countries and a few studies in Eastern Europe, but we need more because we need validated screening tools in your particular context. We need evidence-based practices. We need to know, what does trauma look like in your culture, in your country, and how do you culturally treat someone with chronic trauma in your particular context, in your particular culture, and also tracking data. As I said, there's a big problem with data. We need better tools to track data in your particular area and then have standard indicators, objectives to then look at this on a global level. So training is the next one. Here I am a few years ago training doctors in Cambodia. So we need to equip our peers to understand what human trafficking is. We need to develop hospital policies and protocols. How are we going to handle somebody that comes through our doors? What do you do if you suspect someone is being exploited or enslaved? Then what do you do? It's like when you order labs, like you have to know when you order a particular lab or a particular kind of X-ray imaging study, you have to know what you're going to do with the results. So this is part of identifying victims. You have to know what you're going to do once you've identified people. And then we need training in trauma-informed services. The doctors, nurses, even the receptionist, other support staff, social workers, they all need to understand what trauma-informed care is and how they can give it. So identification, I've also mentioned, we need to recognize the signs of trafficking. We need to understand the barriers to disclosure. You know, if someone is in such dire straits, if they're having such problem, why don't they just tell us they're trafficked? Well, there's a lot of reasons, which is also another talk. And then we need to know what I mentioned, proper referral and having those protocols for handling someone with care. So there's also disclosure barriers. This will be in the notes. I want to make sure I have time to cover everything, but they're very distrustful. We don't give them an opportunity to disclose. They're ashamed, or they don't even know that they are being trafficked some of the time. So we can ask questions like, is someone forcing you to do something that you don't want to do? But they may not want to answer that if they're afraid of retaliation by their traffickers. And so they also have guilt because they've been forced to do illegal things. And they may be afraid that they'll be prosecuted for those criminal things that they did while being trafficked. So through awareness and knowledge of signs, plus good listening and non-judgmental awareness, we can improve identification of victims of human trafficking. So finally, service and clinical care. I talked about breaking down the barriers and trauma-informed. We need, in order to develop a good rapport with our patients, it's more than just being a good doctor, technically speaking. We need to be able to have a good trust, and that means getting through a good informed consent. That means treating with care, going slow, explaining how you're going to move through the physical exam, all those kinds of things. I literally have a 3-day workshop on trauma-informed care. So that's all I can fit in for this 30-minute talk. But there's health consequences. As I mentioned, Nina had chronic headaches and neck pain and GI distress. And so it's their whole body. It's not just the occupational hazards like someone trafficked for construction work and they have some physical injuries. It's not just that someone trafficked for sex work is not just going to have problems with their reproductive system. They're going to have whole body problems. And so here's some pictures of, at the top is someone who is shelling shellfish and shrimp. And there's cotton pickers in Uzbekistan and brick kiln families employed in brick kilns in India, for example. Let me go here. Other farmers. The bottom is a ship. Those are probably from Burma or Malaysia, slaves on a fishing ship. So, but I want to say that the body keeps the score, and the memory of trauma is encoded in our organs, gut-wrenching emotions, autoimmune diseases, and skeletal muscular problems. Like, this is why Nina had so many complaints, but yet the doctors could not find a particular source of a disease manifesting in her body, because I don't want to say it's psychosomatic. The pain is real. They do have real problems. But you need to understand that a lot of this is related to trauma. And so being able to feel safe with people is probably the single most important factor in mental health care. And so you may think, when I first started doing this, I thought I was just doing physical body. But I soon realized that the physical body is secondary to our spiritual self and our mental and emotional self. And then everything is connected. This is not new to you, but it's so much more profound in survivors of trauma and trafficking. And so trauma-informed care briefly shifts from what's wrong with you to what happened to you. And so any support given to victims of trafficking needs to be given in a way that restores a sense of control for the victims over their lives. And so we need to provide support. We need to provide care that is not against their will. We are asking permission, and it's all in accordance to their own self-control and agency, safety, and acceptance. And so this is one of my, I like Richard Rohr's quote here. So when we can see the image of God where we do not want to see the image of God, then we see with eyes not our own. And this can be tough, as I'm sure in your own practice with all kinds of patients, but especially with people. There's a picture of some transgender women there who this is from a scene in Bangkok, and you see people really torn down. Some of these people are very angry. They're not going to throw their arms around you, say, thank you, doctor. They're going to be distrustful and sometimes not the most cooperative patients. But when we see people with God's eyes and not our own, then that is where we make the most progress. So I want you to understand that you, doctors, have a unique and important role in the fight against human trafficking. And it doesn't just have to be in the realm of clinical care. There's lots of different ways that you can help fight, and not just caring for patients. There's some other resources. I'm happy to share web links, and I've got all kinds of stuff on my website. A resource list with links, books, articles, all kinds of things. I want to put the orange cover in the back. That was published in 2009. It's forget all the translations that have been done, but anyway, I helped write that back in the day, and it's available online, free download from the IOM. There's my information, my website, and my email. I want to let you know that I run a webinar every other Monday. The next one is on November 2nd for 1 hour. I talk for only 15 minutes, and then the rest of the time is questions. and it's all about health and human trafficking. I also have a YouTube channel. You can find all that on my website. And I'd love to hear from you. I'd love to visit you. I want all of your questions. I want to help you, help me fight human trafficking. And I think that, yeah, that's it. So wow, that's amazing on the time. And now time for your questions.
Thank you very much, Katherine. We've been listening to Dr. Katherine Welch, MD, talking about the role of health professionals in addressing human trafficking. And we've got about half an hour now for Q&A, which is great. First of all, from Dr. Trevor Stammers in the UK, who's saying, every surgeon who transplants an organ of unknown origin or physician who sees a patient who has a new kidney from, say, China or India with an unclear story of how they got it is also involved in human trafficking in a form which could not happen without essential medical cooperation. Difficult question, why do doctors become complicit in this way?
Yeah, Trevor, that is 100% correct, that they are complicit. And sometimes, not always, it might be that they are unknowingly complicit. And so they're complicit by choosing to not recognize it. But I think there's several reasons why they are. And that is, they don't know what to do. There's no hospital policy, or they don't know, or what do you do? Because a doctor should say something, and there should be a way. There should be a referral mechanism. The hospital should have a way to deal with this situation. They should train their doctors about when you see something, say something, and then have a policy to deal with it. And also to recognize and then help more doctors recognize the problem. And also they should care. They should not just care. I think sometimes people get busy, they're overwhelmed. Transplant surgery is not an easy profession. There's a lot of stress. I think it's easy to just, well, that's not my problem. I'm just a technician here. That's unfortunate. I'm pretty sure that's what happens. And, but yeah, that's completely right. I think it's raising awareness. I think if a surgeon is seeing this and feels like he or she can't say anything about it, then I think that person needs to start something at their hospital or region to start looking at, hey, this is a problem and we need to do something about it. Because I don't buy that, okay, one person may not be able to do something about that one case, but that one case may catalyze an entire movement at that hospital, in that city, in the region, in the country, because it's very, very, very corrupt. And it's something that's not, it's terrible how this is going on in so many thousands of cases around the world. And the trafficking of victims for organs is, it's sick. It's just sick. So anyway, I'll get on to other questions. So what's the next question up here?
From Hedwin Kadrianto. So Hedwin's a dentist in Java in Indonesia. Can you share the impact of the COVID pandemic on human trafficking globally? Has the pandemic reduced it significantly because of less travel? And how should rescue or ministry organizations make the right approach in the current situation where movement is limited? How has it changed the way that they should be doing their work? So it's really about the impact of COVID and the impact of it on our response.
That's an excellent question. Actually, no, the pandemic has not reduced human trafficking. I think it has just shifted it. Whereas they were migrants. I know in some respects, even though I'll take an example of Africans being trafficked to Italy, because I happen to know more about that situation. I also happen to know about the situation about migrant workers being trafficked. It has not decreased, although I don't think that our mechanisms for being able to track the trafficking has caught up with the pandemic, but they're being shifted. So instead of going to Italy, I think a lot of, for example, the sex trafficked people are going to the Middle East. That's what I've heard. And they're finding other sneaky ways. And the pandemic is forcing a lot of sex exploitation online. And so it's not reduced, it's just looking different, where the people are being shifted to different areas and they're being trafficked in different ways. And also, it's just created a greater vulnerability, because the migrants, while they had terrible conditions, say the Nepali working in Qatar, building the World Cup stadiums, when they were sent home, then they have no more money. And so it's just created a lot more desperate people who are willing to take even greater risks and have even greater suffering in a exploitative situation. So it's part two. Part two was, how can organizations shift? Well, in one, regarding those reaching out to, and I'm guessing it's anti-trafficking organizations and not specific to healthcare, that a lot of the work has shifted online. And so they're doing online outreach to actually just following up the contacts that they already had, but also initiating, taking up ads in certain places where people are selling sex online, online advertisements. And they're setting up advertisements for help and outreach and trying to do outreach in that way. As far as the labor, I think there's also been some initiatives where they've moved also for online awareness raising or through ads. Whether it's radio, whether it's online ads, whether it's text messaging, whether it's community-based low-tech strategies that organizations have had to shift to reach the vulnerable population, to educate them about what's going on and what are the new risk factors. I would say that the anti-trafficking movement was really caught off guard. I think also the traffickers probably were, but I think the traffickers move faster than the anti-traffickers. So I think it's, as far as initiatives to shift, it has to be now very local and very particular to a particular situation. I can answer further questions, but there's more questions coming up. So.
Yeah. Now, Katherine, you said earlier on that feeling safe with people, you said, is the most important factor in mental health care. And a question here from Liette Pilon: how do you get victims to feel safe and trust you in the consultation?
Yeah, that's such a good question. I'll try to boil it down into a couple of sentences. Like I said, this is a whole day training that I do, but I think a lot of it's we can't forget that 70-80% of communication is body language. And so culturally appropriate motions, like either looking people in the eye or not looking people in the eye, feeling comfortable, putting down your tablet, putting down your notebook, looking at the patient, asking how they are, speaking slowly, asking, I think that's a good start, and asking if they're comfortable. And also, as doctors, we can explain about what we're doing and saying, even though, putting a stethoscope on someone's chest is very routine, our normal patients will accept that. But for someone who is traumatized, you might say, now I'm going to examine you. Is that okay? And I'm going to put my stethoscope on your chest, being very gentle, explaining what you're doing. Especially, and now you're saying, I'm going to move to the back, because it can be traumatizing for someone. If you're going to be doing something where they can't see you, then I think taking care on those kinds of things, it almost seems so simple, but yet that's what is most profound, in simple ways. And being gentle with somebody and taking time and making sure that they understand, not rushing through things. And I think that's when you're on initial encounter. I think also going through, we think of informed consent as only getting the paper signed before surgery, but I think we need to take this to a more fundamental way when we're dealing with a patient in the clinic room. And so understanding that's the initial first steps. Of course, there's more to say, but we'll go on to the next question.
Thank you. Thank you. That's great. From Evelyn Sharp now. Evelyn is a psychiatrist in the UK who's done a lot of work in caring for the carers, particularly people coming back from mission or traumatized situations. So, and she's asking you, Katherine, how do you find support for yourself in dealing with so much trauma? Because you must see some pretty terrible things. So where do you find support and resource in coping with this?
That's an excellent question. And I would encourage everyone to examine their own way of doing their own self-care. And so for me, I like to run. I run quite a bit. And so the more stress I got, the more I run. But it's not just running, it's the physical exertion of the energy, but I also run. I mean, I will run for 2 days. In some races, it takes me 2 days to complete, but no headphones. When I run, I'm either listening to myself, I'm listening to God, or I'm just in a Zen like meditation mode. So my running is a form of meditation where my body is active and I'm not distracted. I'm only in my head or in my heart praying. But I also have, I make an important point to reach out to good friends, people who will not think I'm crazy no matter what I tell them. No matter what I tell them, I have to tell, and they will accept me and not think I'm crazy. And those are very important, because if you tell the wrong person sometimes, then they will think you're crazy, and that would not be good. And they might, but I think it's important to have both their internal things that you like to do alone, and it's important to have those external outlets as well, so that you can feel you're in a good community.
Thank you. Another question from the Southeast Asia, from Marissa Resulta, who is a pediatrician from the Philippines. So she says, as a child protection specialist, I've seen an increase in child abuse cases in my country during the COVID pandemic. Are there any changes in how you would manage child abuse cases and human trafficking in this so-called new normal?
Man, that is the truth. That is happening everywhere, unfortunately. Yeah, I personally am not managing child abuse cases. I think, however, in this case, we have to do what we can in person, as much as we can. And hopefully, as restrictions are lightening up in some countries, and some countries are going back up. But I think improving outreach, I think reducing shame among children. The problem with children is that they can't actually be proactive in accessing help. But we should be actively promoting teachers, parents, other caregivers who might be noticing that, and have more online resources and online help. How do I want to say, channels, I guess, channels for people who are noticing this. And maybe there's a way for children to be able to contact people themselves. I mean, if the children are getting online in amazing ways, in ways that we never imagined even a couple years ago. But I think it's as utmost important to actually be on the preventive side and continue to keep our children away from devices, restrict those devices, and also talk to children about what's right and what's wrong, and who they should be talking to and who they should not be contacting online. I think a lot of it has to be protection and prevention on the front end. But as far as dealing with it, I think increasing our ability to help equip and increase the channels for reporting and also the therapy as we go. And I'm not sure, that's not something I've looked at. There's so much to look at these days. I'm not aware of any specific resources I can point to you right now.
Thank you. Another question from Hedwin in Indonesia. And he says, you've already mentioned many Southeast Asian countries during your talk, and it's true and sad that human trafficking is a huge issue there, Thailand, Cambodia, Bali, and so on. So he's asking a practical question, how possible is it for them, so we're talking about ICMDA in Southeast Asia, to collaborate with you to do a virtual training for Christian healthcare workers in Southeast Asia? So there's your first offer, Katherine, of a request. How many days are needed? How many hours per day? Do you have any branch or people, trainer based in Southeast Asia? Now I can connect you afterwards with Hedwin to continue this, but perhaps you'd just like to answer it in general terms so that others have a better idea of the kind of in-depth training you do and what you offer.
Yeah, sure. And just so you know, I moved to Thailand in 2000, and in 2004, I moved to China. And then in 2011, I moved back to Thailand. So I spent 19 years in Southeast Asia before moving to Europe. So there's a wide range of talks. So I do a lot of speaking. I can have talks for non-healthcare practitioners, but also healthcare practitioners. The trainings involve a lot. Basically, it's a broad expansion of this 30-minute talk. And we go into a lot in depth of what does it mean to identify somebody? How can we improve our skills for identification? Then what do you do after identification? How can we work a referral that's safe for the victim? And then also in terms of trauma-informed care, I work through a lot of the psychological aspects. I work through a lot of how trauma affects the brain, but as well as the body. And then how as physicians, we can be better equipped to look at these issues and treat the person wholly. And I know it's Christians, we get that, especially on a spiritual basis, but also what does that look like on a practical medical issue? And so as far as doing these trainings, yeah, I think in this online world, it used to be, I'd be able to come and fly in and do as many, 1 day, 2 days, 3 days. But for doing online, I think we have to be a little bit more creative in working with the times. It could actually be longer, but shorter segments on the time. So there's a lot. And also and then connecting, actually, I do not have any physician or health trainers in Southeast Asia, but I do have other contacts with non-medical professionals with whom I can connect you with that can provide some other ground support or training about human trafficking, or connecting, as I said, in a multidisciplinary way, because these organizations need doctors, and they desperately need trauma-informed doctors who can care for their beneficiaries in a way that's not traumatizing. I think it's important. I'm going to say it again. Doctors can re-traumatize someone without even knowing it. And sometimes just in the normal practice of the way we give care, sometimes, we don't intend it, but, it can cause some, it can be traumatizing. So it's important to know those ways and to help mitigate those kinds of problems. But yeah, I'd love to connect with you on a more details on that.
Thanks. We can certainly arrange that after the webinar. A question from Daka Soladuka is saying, are there global hubs of trafficking in the world? And if so, are governments involved in it at any level? How high up does human trafficking go?
Well, I mean, if you look at China, I mean, it goes all the way to the top, because they've got state-sponsored slavery and a human organ trade in China that's sponsored by the state. Also, probably there's some Middle Eastern countries. I mean, yeah, there's slavery going on in Qatar, North Korea. There's a lot of complicit. And whether it's outright or whether it's just corrupt government officials, there's a lot of that. There are organized crime is huge. And so you've got some portals. For example, you can see, we saw a lot of people from Uzbekistan in Bangkok, also from Eastern Africa and Uzbekistan, in particular countries in Bangkok for sex slavery. But in another country, you might have also, but the Thais are being trafficked to South Africa and the Middle East. And so you've just got the traffickers who've greased the portals of immigration somehow. So a lot of traffickers just work very locally, or it's very, I would say, decentralized in some ways, because it's easier to move about and stay fluid and not get caught that way.
Are you able to comment on trafficking in North America? Abe Nyden is asking.
Yeah, sure. I think, there's a couple of sets. In fact, as far as sex trafficking goes, most of the sex trafficking is happening to Americans. As far as labor trafficking, they're using a lot of people from, Central and South America. And like I said, there's a whole spectrum of human trafficking, exploitation, and general just labor abuses. So it depends on how you make the definition. So there's, and as far as America is actually doing quite a bit as governments go. Back in 2000, like for 20 years, they've had a Victim Protection Act. And so this has not been a recent development. For the last 10 years, America has really developed a whole healthcare plan. And so in fact, it's required now in many states for doctors to get continuing medical education about human trafficking. And so there's more and more doctors and nurses being educated about human trafficking. And there's a network of referral, and more hospitals are learning how to deal with that. And so I think that's one good thing. The problem is that we're not, I think it's a huge problem in America still, even with that. It's still way too many people getting trafficked. So that was a pretty general question. I hope I answered that for you well. So we've still got quite a few questions here.
Yeah, still quite a few. So different question now on supply chains So how can developing world countries compete with Western countries if we're using a modern definition of employment law? Isn't it that most supply chains use developing countries and therefore channeling a lot of money to them because of the lower standards of employment law? How can we address this sort of issue?
Okay, generally, I think, yes, that is true. I think there needs to be a lot more transparency. For example, we'll look at the cocoa, because I have good friends. And also I'll put a link, I'll put a plug in for my good friends at Be Slavery Free. And I don't know if there's show notes, but it's beslaveryfree.org, one word. They're out of Australia, and they're doing brilliant job tracking tea and cocoa and what else? Clothes, all kinds of things. So it's about encouraging, getting the governments, getting companies, like they're working with Nestle and big cocoa companies to really work on saying, listen, this is a problem. We need to support those communities, those villages that are, you need to pay the farmers more so that they don't make their children pick the cocoa. You need to pay them so the kids can go to school, pay them a living wage, pay them a growing wage, pay them a wage that's worth it. And then ensure that there's transparency all the way through, and giving a leg up, because the multinational corporations can afford that and bring up the whole system together, not just piece by piece, but working in a multidisciplinary way, getting organizations, governments, and local farmers and things together. But what I see is that it seems to work better when you're tackling a particular industry in a particular region, such as what they've done in Cote d'Ivoire and Ghana or other West African countries for the cocoa trade. And then there's also an initiative in tea and garment factories in South and Southeast Asia, things like that. So yes, it's hard. It's a lot of work, but we have to try.
Thank you. Unfortunately, this might have to be our last question because we're almost out of time. But Shari Falkenheimer, who you may well know from CMDA in the US, yep. And she's asking about best practice models. What countries or areas are dealing the best with human trafficking, and what can we learn from them specifically?
Well, I mean, I mentioned as far as educating healthcare practitioners, I think America is doing a decent job. There's a lot of things we can learn, but it's focused on the American healthcare system, such as it is. That a lot of that may or may not translate to other countries. Let's see. That's a. Actually, I think you'd have to look at the particular issue, and whether countries are doing something good about it. I mean, it's always easy to pick the bad ones. I think the UK is starting to look at this. Australia has passed a Modern Slavery Act, or actually they're still trying to get it through. They keep knocking out some of the provisions. So I think having countries like that passing, broad legislative initiatives under which, gives an umbrella under which many more projects can be funded and recognized as valid. I think that's a good way. I think, I mean, there's other organizations that are doing things in spite of the country. That's my two thing. Actually, no country is doing like really awesome.
Well, there were some comments in the chat saying that the UK is well renowned, but we're not quite sure that we're doing as good a job as we think we are. And
That's true.
As you've said, this is a huge challenge. Many people are not aware of it. Thank you so much for making us much more aware and firing us up on this issue. And I hope this will lead to many other opportunities for you and many of these listeners being more aware and being more involved to counter this problem. So I'm afraid that's all we've got time for today. We've been listening to Dr. Katherine Welch on the role of, did you want to add something, Katherine?
No, I was saying, join my webinars. If you want to ask a question, join my webinar and you can ask me again, okay? And excellent. You can ask anything. And so join me again, just find out, all the links will be there. Yep.
Great. So we've been listening to Dr. Katherine Welch on the role of health professionals in addressing human trafficking. And thank you everybody for joining us. And we hope we'll see you again very soon on ICMDA webinars. God bless you and thank you.